Thank you. I want to welcome commissioners and members of the public. This is another remote-only commission meeting. Hopefully, we're getting toward the end of the remote-only meetings, and we'll get back to in-person meetings soon. But given that this is a remote-only meeting, the additional ground rules apply. I'll begin the meeting with a roll call of the commissioners. During the meeting, I'll ask that people speaking identify themselves before doing so, and I'll remind you if you forget to do so. That way, commissioners and members of the public will know who's speaking at all times. We're using Zoom today. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless I recognize them. Due to the possibility of background noise, I do ask that commissioners and others mute their phones when they are not speaking. For this meeting and at future remote-only meetings, we'll post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register and dial into the meetings by posting that information on the homepage of the website and on our various social media outlets. I'll now call the roll. Commissioner Akintade.
Here.
Commissioner Bandari.
Here.
Commissioner Boyer. I see you. Commissioner Boyle. Saw you. There you are. Commissioner Brumbaugh.
Here.
Commissioner Cheatham. Did not see her before. Okay. Commissioner Dordon, saw you.
Here.
Commissioner Jensen. I know Commissioner Metz will not be joining us today. Commissioner O'Connor. Dr. O'Connor? No. Commissioner O'Grady?
Here.
Yep. Commissioner Sargent?
Here.
And Commissioner Wang?
Here.
Great.
Hi, it's Dr. Cheatham. I'm sorry, I may have missed you calling my name.
There you go. Thank you. Thank you.
Dr. Pollack, Commissioner Jensen was on our lunch call momentarily. Has he joined?
He did not acknowledge if he has joined. So we'll proceed for now and reach out. We don't have any important action items coming up. We do have a very important action item. I forgot the approval of the minutes. Included in your packets are copies of the minutes from the December 16, 21 public meeting that took place in person and by video conference. I'll entertain a motion to approve those minutes.
So moved.
I'll second.
Second was Commissioner Akintade. All in favor?
Aye.
Any opposed or abstained? Very good. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Okay. Does the executive director have any updates?
Thank you. Thank you, Dr. Pollack. A short update today. First off, as all of you know, the legislative session began last week. We have 4 commissioners who will be up for reappointment over the legislative session. Typically, those the governor's appointment office will contact you directly to let you know that your consideration for reappointment. In the past, commissioners who are up for reappointment, like all individuals who are already holding a board or commission position, did not have to reappear at the hearing of executive nominations on Monday evening. I'm going to assume that that will be the same situation this year, especially because we're virtual, but please pay attention to the communications from that you would receive via email from the governor's appointment office, because they will give you further details. And it's always best to assume that there's a possibility things would change. You will note in the minutes from December that we did insert the progress report on our our efforts to continue to meet our strategic priorities. I reviewed those verbally with you in December. They are included in the minutes for December if you want to go back and check that out. This will be a semi-annual update. Every 6 months, we'll review our progress on strategic priorities, so expect another one in July. I also wanted to call your attention to the update section this month. We've added a new section called Notices of Acquisition and Change of Ownership for Comprehensive Care Facilities, Nursing Homes. Given the considerable interest in change of ownership on nursing homes, we are providing a brief synopsis of these acquisitions as we receive them. Please take a look at that in the update each month if you have questions. Note that the change of ownership is not a commission action, but given what we've seen over the last several years, we do want to raise awareness on the part of commissioners to the nature of acquisitions that are occurring in the state. There continues to be considerable interest in the community and in the media regarding acquisitions of nursing homes across the country, and we continue to communicate our role in those processes, and note that unlike CON's establishment of new facilities, the commission has very limited authority in its review of acquisitions. As you know, in December, we began our conversion to our new APCD contractor, OnPoint Data Systems, based in Lewiston, Maine. That work continues to go very well. OnPoint also just announced in December that they had been awarded the contract for the APCD effort in California. So they have added a number of states over the last several months. We'll be monitoring their progress and keeping a close eye on their work as they continue to gear up to support the submission of Maryland claims. On a positive note, the initial submission that they were responsible for went very, very smoothly, and we're optimistic that we'll be able to accelerate the release of that information to our other stakeholders, primarily other state agencies, to make the data more quickly available. Lastly, on areas that were not covered in the update that I wanted to flag as important work areas that I expect over the next several months. First off, and in our total cost of care engagement with the department and HSCRC and hospital systems, there have been some interest in determining whether it is possible to better align the Medicare Advantage program in Maryland with other total cost of care initiatives, including the Maryland primary care model. We will be working with colleagues in state government to look at what the options are. As many of you know, Medicare Advantage, operating as Medicare Part C sometimes, has relatively low uptake in the state. There's potentially a number of reasons for that. Oftentimes it's pointed to the fact that we have a hospital rate setting system that limits negotiation. I don't think that's the only reason, but it is oftentimes used as a principal reason. As we move into the new model, there are financial advantages to beneficiaries if they are able to join a Medicare Advantage program, if a tightly managed network is appealing to them, and we'll look to take advantage of that. There are also potentially advantages to our total cost of care test if we are able to engage more Medicare beneficiaries in a more tightly managed care management services that theoretically would lower total cost of care for those beneficiaries. We've seen some renewal in interest in assignment of benefit legislation. Some of you may remember about a decade ago that Maryland Healthcare Commission was involved in assignment of benefits in situations where a individual is using an out-of-network provider. More recently, in 2020, the no surprise billing legislation at the federal level passed. This past fall, the federal government released its interim regulations regarding how it would actually apply assignment of benefits for when a patient seeks care from an out-of-network provider. The interim regulations have sparked some concern in 2 lawsuits at the federal level by the American Hospital Association and the AMA, contending that the interim regulations don't comport with what was intended in the establishing statute. I think that partially is the reason why we've seen some interest here in the state. We'll keep the commissioners abreast on any additional role that the commission staff is asked to play in that area. And lastly, we've also seen some additional interest in mandates. That was one of the retail roles of the commission prior to the passage of the ACA. Mandate legislation declined after the ACA was passed, but we're beginning to see some interest. The scope of mandates is quite limited because of the federal authorities in the ACA, but we do see some additional requests for us to provide an estimate of the impact of several mandates. One that is especially expensive is expansion of in vitro fertilization. Historically, we've seen that have a significant price tag. We have not received any requests to provide estimates in that area, but I wanted to alert you as that's a possibility. And you'll hear more from Tracy later on in the meeting, but happy to answer any questions right now.
Thank you, Ben. Any questions for Ben? I'll note for the record that Commissioners Wang, O'Connor, and Jensen have joined the call.
Excuse me, one quick question.
Yep.
Ben, in this sort of area, do we have a working relationship with an actuarial firm or someone else to help us with the estimates of mandates?
We don't have a contract in place currently. We've had conversations with one actuarial firm, but we haven't signed a contract yet. What I'm hoping for is our authority is defined rather oddly in that the MHCC can provide an actuarial estimate after a mandate has failed in the legislature. So since
that's interesting.
So we might have a year to look at this,
Yeah.
but we might also have the opportunity to provide more informal input in this session if it looks like something is going to pass on its first go around. Historically, mandate legislation took kind of like a couple of years to get through the legislature. This was pre-ACA. As I've noted, we haven't seen significant amounts of mandate legislation over the last decade or so.
Thank you.
Very good. Other questions for Ben? Hearing none. The COVID numbers throughout the state over the past week seem to have improved slightly relative to where they were. I believe our positivity rate today is down to 18% from a high of very close to 30. And for the first time in about 2 weeks now, I believe we dipped below 3,000 admitted patients. But in early December, we were closer to 500, just to put into perspective the increases over the last month. This has been largely attributed to the Omicron variant. And despite Omicron causing less severe infections, the number of cases has the potential, at least, to overwhelm the healthcare system. We've gotten close within the past month. The governor has responded by instituting a 30-day state of emergency, has expanded testing centers, and deployed the Guard to support the system. Today, we've asked Ted Delbridge, the executive director of Mhcc, and Bob Atlas, the president and CEO of the Maryland Hospital Association, to provide us with some situational updates on the EMS and the hospital systems. We'll pause for questions after Ted's presentation and then ask Bob to provide the hospital update. So, Ted, please proceed. Thank you for joining us.
The opportunity to just provide a quick update about the challenges of the statewide EMS system and some of the responses to the COVID-19 pandemic. And some of what I'll describe represent challenges that were ongoing and merely exacerbated by the influx of patients related to COVID-19. Next slide, please. No, undoubtedly, you've seen graphics like this that represent the numbers of people in the hospital in Maryland over the course of time since March of 2020. And I bring this up, to emphasize what Dr. Pollack mentioned. We seem to have hit a peak, hopefully a peak, on January 11th of 3,435 patients in the hospital, adults, that has been decreasing over the past few days. But what is interesting to me about this is that this represents a product of the EMS system. Maryland is fortunate in that we have what is called the Maryland Emergency Medical Resource Alerting Database, where we can query a hospital in short order about potential needs and immediate resource availability. And we've been exercising the system's meant to be used very infrequently. We've been exercising it on a daily basis since March of 2020, and the hospitals reliably respond every day with a query of about 30 questions that gives us this data. And so the data that you see about hospitals that end up mostly being manufactured by CRISP, they help us with the graphics and make it look pretty, really as a function of the EMS system and an elaborate collaboration between the statewide EMS system and the rest of the healthcare system, including hospitals. Next slide, please. This is one of the manifestations of collecting that data. We've been tracking for some time the number of patients that are boarding in hospital emergency departments. So consider a boarder somebody who is really complete with the emergency department aspects of their care and is stuck. Whatever is supposed to happen to them next is not available. And it might not be available because there's not a bed available, or it might not be available because in the case of, for example, as I'll show here in a second, behavioral health or psychiatry patients, there's no ability to acquire an acceptance of that patient in some other place. On a good day, when we take this snapshot, which is what this represents, a point in time, usually right around lunchtime, like between 11 a.m. and 1 p.m., there are generally 250 to 350 boarding patients in hospital emergency departments. Earlier in January and throughout December, that number has been approaching 400 and 500 and above, as you can see there. Next slide, please. So we endeavored way back in November to do a more elaborate look at who and what represented a patient boarding in the emergency department. As I mentioned, at any given time, there might be between 200 and 350 or more patients boarding in hospital emergency departments. And this was based on a 10-day analysis where we tried to capture every day of the week. And what that means is that 20 to 25% of patients in Maryland hospital emergency departments at the time you might take a look inside the emergency department are boarding patients. So 20 to 25% of patients who are occupying space in the emergency department are no longer in need of emergency department sort of care. They're really ready for what comes next, and that what comes next is unavailable, as I mentioned. It turns out that medical patients in that snapshot have been there for just shy of 7.5 hours waiting for the next step. Behavioral health or psychiatry patients, on the other hand, are there on the order of almost 34 hours at the time of the snapshot. So what that means is behavioral health or psychiatry patients represent about 25% of boarders in emergency departments, but represent about 68% of the boarding time. So really a disproportionate number. And so there are efforts going on to capture in a better way the availability of psychiatry or behavioral health beds to better match the patient's needs with the available resources. And what ends up happening is that we this is, I think, important to the Healthcare Commission. What ends up happening is there might be space available, but the space doesn't match the patient's specific needs. And the default move, instead of putting the patient in the available space, waiting for the most optimal space to be available, as the patient stays in the emergency department stuck there, which is probably not an optimal situation. Next slide, please. What is remarkable is the way that the hospitals have been using what we call the alert status, or CHAT. It stands for County Hospital Alert Tracking System. The hospitals can declare themselves, it's really rather subjective, on a yellow or red alert. Yellow means that the emergency department is busy and they would request of EMS to go to any other hospital within reason, unless the patient is in dire need of immediate care. Red alert means that the hospital doesn't have any monitored or cardiac or intensive care beds. And as you can see there, the past 2 years, essentially, the use of yellow alert on a daily basis has gone up dramatically. This slide represents the number of total hours that hospitals are on yellow alert at any given time. When you get to about 400 or 500 hours, you basically take 25% of Maryland hospitals offline of the EMS system. This is problematic for a bunch of different reasons, not the least of which is it creates false expectations of the hospitals of what the EMS system can do, and the EMS system can't respond when it's more than just a couple of hospitals on at a time. The system was meant to capture extraordinary circumstances, but we've sort of normalized extraordinary. The red line is basically my guess at what an average should be. Next slide, please. This is a snapshot of Region 3, so the Baltimore metro area, on one day in December, when, as you can see, every hospital is basically on some sort of alert status, and there's nothing the EMS system can do to respond to that. And again, it just creates false expectations and a little ambiguity and animosity, really, between the field personnel and the hospital staff, when the field personnel are unable to respond to what the hospital staff think they've sent out as a signal saying, don't come here. Next slide, please.
Ted, just one question. If you go back to that last slide, I just want people to be aware that's December 13th. That's
Yes.
before the Omicron surge, right?
Right. It
Yeah.
has been
That's our base.
worse on other days. Next slide, please. And this is just a year-over-year graphic. To the right is where we are recently, and to the left, it goes way back to more than a decade ago. The use of the yellow alert status in all 5 systems or 5 regions. And so you see our hospitals are, it doesn't really matter what I personally or anybody else might think of hospitals need to be on alert or not. It really signals a level of distress in the hospitals. For some reason, the hospitals are stressed and needing to claim this status. And I think that's worthy of looking into. Next slide. What that manifests into for the EMS is the inability to deliver patients. This graphic shows how, on a per hospital basis, how long it takes EMS personnel to transfer responsibility of care from themselves to hospital emergency department staff 90% of the time. And our goal is that 90% of the time, we ought to be able to effect that transfer for EMS patients within 30 minutes. So that's not the time the ambulance is parked outside as they clean up and do all those kinds of things. This is strictly the time that it takes for the nurse in the emergency department to say, put the patient in that bed and you're dismissed, essentially. And as you can see, a minority of hospitals are able to do this. This represents 2021 over the course of the entire year. And it only got worse in the last month or so. And so you can see we have a lot of work to do to get hospitals able to do that. So imagine, if you will, a citizen calls 911, they expect the closest help to be dispatched. They expect an ambulance to arrive within a couple of minutes, and reliably they do. We have expectation to be on the scene for short periods of time, and we monitor that, and the local jurisdictions do. And then you expect expedient transport to the hospital or the healthcare service you're presenting to, only to wait in a hallway for some protracted period of time. And recently, as of last week, the median transfer time in Region 3, again, the Baltimore metro area, was about 24 minutes, and fairly representative of the entire state. And the 90th percentile is 70 minutes. So more than 13% of the time, it takes longer than an hour to effect transfer of a patient from the EMS personnel to the hospital emergency department staff. Next slide, please. So to the things we did. So we tried to find different ways to alert the EMS clinicians, the EMTs and paramedics in the field, as to the status of various hospitals so that they could make a better informed determination about where they ought to go with their patient and have a more reasonable discussion with patients about what to expect when they got there. And so we created AHA, the At Hospital Ambulance Dashboard. And so this updates itself every minute or so, and it indicates how many ambulances are at every hospital and how long the most recent one got there and how long the longest one has been there. And so if I am a paramedic in the field, I can see that at Baltimore Washington Medical Center, there are 3 ambulances there currently. The hospital is on yellow alert. The most recent ambulance got there 16 minutes ago, and the longest one has been there 61 minutes. And if you have a login credentials, you can actually click on that and you can find out who those units actually are. The advantage is that for Anne Arundel County Fire Department, for example, they might know of Anne Arundel County Fire Department units that are Anne Arundel Medical Center or Baltimore Washington Medical Center, but they can't tell who's there from Queen Anne's County, Calvert County, Prince George's County, or Annapolis. And so this allows them to see everybody at one time. And so we are in the process, we've been disseminating this for the past couple of months and in the process of making sure that people are using it to its total capacity. As you can see on this, the other thing it does is it lets us know when the EMS system didn't do a good job. As you can see on this particular moment at Anne Arundel Medical Center, there were 10 ambulances. And if you look into them, they came from different places for different reasons. And some of those patients needed to be at Anne Arundel Medical Center specifically, but some other ones maybe not. And so this allows us to go back to the EMS jurisdictions and provide some education. Next slide, please. One of the other things we did is develop the viral syndrome pandemic triage protocol. We are interested in keeping people out of the hospital when they didn't necessarily need to be there. And this is a tool that we gave to the EMS system, hoping that EMTs and paramedics would encounter low acuity patients and be able to identify them and have a reasonable conversation with the patient about maybe their expectations and provide, it's linked to home care instructions, just like you would get if you went to the emergency department. And several jurisdictions have done other things like add-on where testing centers are and things like that, in hopes of identifying patients who really weren't going to benefit by going to the hospital. I can tell you that of all the persons under investigation, I'll show that slide in a second, that we identified, the largest single disposition is keep the patient at home. And we are able to track when this particular protocol is used, and we know that 3% of the patients subsequently require hospitalization in a reasonably follow-up time, which is as good as you might expect if the patient actually went to the emergency department. So we've had pretty good traction, and we know when people make decisions without using the protocol, we're not quite as good. Next slide, please. The other thing that we did is create a directed triage protocol. So we're not delusional. Some patients that go to the hospital by ambulance really probably could have gone someplace else, like an urgent care center if one was available to take them to, and or insisted going to the hospital when maybe it wasn't entirely necessary. And we want to empower EMS clinicians to identify who those people are. And instead of putting them in a high priority queue at the ambulance door to the hospital, put them in a lower priority queue, just like everybody else who managed to get themselves to the hospital, the other 75% of patients who arrived at the same emergency department, who got there by driving themselves or getting a ride and walked in, and let the patients fall in the queue with those people. As somebody that used to manage an emergency department, it's incredibly disruptive to interrupt the queue. And so it's appropriate to do that when somebody is seriously hurt or ill, but not so appropriate to do that when the most injured or the most ill patient is actually somebody sitting in the waiting room. And so we've tried to do this and emphasize to all our EMS jurisdictional constituents and to hospitals to make this work out. It doesn't obviate the need for an EMS clinician to have a discussion with the triage nurse and provide a quick report and leave some form of documentation behind. But it does say to the hospital, we got somebody who's shouldn't jump to the front of the line. Let us put them in the back of the line. We've had really good success with that. And what that has enabled us to do is to turn EMS units around faster. Because while hospitals get distressed with low staff numbers and closed beds and things like that, the EMS system doesn't have that luxury. When somebody calls 911, they still expect a response. The answer by the operator can't be, well, we had some people call out sick today and so we're not coming. Next slide, please. This is a graphic of the persons under investigation. One of the things that we're really good at in Maryland is collecting data and pretty good at sharing it. And you can see the persons under investigation, how it's gone over the past little while. So there are criteria that allow EMS clinicians to identify who these people are. We track them, we track where they go. We know what hospitals are receiving the most numbers of these people. The blue line is persons under investigation. The orange line is people who told the EMS folks, I have COVID-19. Next slide, please. And one of the things that we're able to show early on, is that this actually correlates to hospital admissions. And interestingly, it doesn't correlate to hospital admissions on the same day. It correlates to hospital admissions 9 days later. Don't ask me why that is exactly. And I'm sure it's very specific to this particular pathogen. And it may have even changed as the variants changed over the course of time. But it tracks pretty well. When the PUI number goes down, 9 days later, we see hospitalizations in Maryland go down. And when it goes up, it's an early indicator that hospitalizations are going to go up. And what that means to me is that the EMS is the tip of the spear, and it's seeing in the community what the hospitals are about to experience about 9 days later. Next slide, please. One of the things that we've been able to do is do post-mortem COVID-19 testing. So there's a proportion of patients who suffer out-of-hospital cardiac arrest that EMS doesn't transport to the hospital. Everything is done for them at the location of the cardiac arrest, and efforts to resuscitate them are terminated at the scene. Well, early on in the pandemic, all those patients became medical examiner cases and were tested. But as the pandemic wore on, that was no longer the case. And it obviated the potential for those people to have appropriate contact tracing, because presumably they were with their relatives and people, close friends, before they had sudden cardiac arrest. And all these people didn't know they had COVID-19. So these aren't positive cases. These are people who had no idea. And as you can see in January, more than 30% of the cardiac arrest TOR cases that were tested are positive for COVID-19. As a matter of fact, what we've shown over the course of time is that the proportion, the test positivity rate among this population is higher than it is in the general population. And so it's overrepresented. What that means is for some people with COVID-19, their very first serious symptom is an out-of-hospital cardiac arrest. And we recently presented this at a scientific meeting. We're the only state that is doing this on a statewide basis that I know of. Next slide. One of the other things that we've done is create the Critical Care Coordination Center. We realized early on that hospitals had intensive care unit type patients stuck in the emergency department because they had no room at their end, and they may have been quite capable of taking care of that patient, but lacked the resources to do that. And they were familiar with their typical referral patterns, but they wouldn't know that, for example, if you were a Doctors Community Hospital in Prince George's County, you might not know that there was an ICU bed available at Frederick Hospital. And so the C4 connects all those dots for people. We do this with an on-call intensivist who is on call just for this purpose at the moment that they're taking call. We use paramedics to field the calls. And so a hospital emergency department physician, instead of calling 15 different hospitals to try to find a bed, they make one phone call. They call the C4. We collect clinical information. The intensivist, when it's appropriate, will provide some clinical guidance, say to the emergency physician that's making the call, or the hospitalist, or the ICU doctor where the patient is. And they try to match the patient's needs with the most appropriate resource in the community, so that not every patient is flowing to a tertiary or quaternary care center. Some community hospitals are appropriate to send their patients to another community hospital where the space exists. We've been very successful in both identifying potential places for people to go, providing feedback, and probably 30% of the cases never leave where they started. The intensivist is able to talk the clinician through managing the case for the next 3 hours or so, and we obviate the need for them to go anyplace. You'll recognize that 69 requesting hospitals represents more hospitals than exist in Maryland. We get calls from out of state when, for example, a West Virginia hospital will call a Maryland hospital and they'll say, can you take this patient? You normally take patients from us, and the Maryland hospital will say, no, we're busy, but call C4, they'll help you. And so we've been doing that. The balance favors Maryland. We send more patients out of state than we take in from out of state. And so as long as that's the case, we'll keep trying to do that. Next slide, please. I think we're one of 4 or 5 places in the country that do that. And I'll try to wrap up really quickly. I think I'm over my time. As you know, there was a new state of emergency declared on January 4th. It gives us a fair amount of latitude to do different creative things, and we've tried to take advantage of that. Next slide, please. One of the things we've done is allow emergency medical technicians and cardiac rescue technicians who aren't typically people that provide vaccinations to be vaccinators. They've delivered more than a few thousand vaccines over the course of time in conjunction with local health departments and health systems. We changed the order of testing so that we don't gum up the process for emergency medical technicians and paramedics to get certified. We've extended licenses. We created a category of provisional licensure for people that are done with school but are waiting their turn to take a test. We put them out in the field. And there's some other categories of those people. We also created this category of people called clinical externs. These are nursing and respiratory care students who the nursing schools and respiratory care programs vouch for their level of education. They designate them as level 1, 2, or 3 as nursing students, or level 1 and 2 as respiratory care students. And they become people who are readily identifiable to the healthcare system to employ, not to replace a nurse or a respiratory therapist, but maybe to extend the ability of a practicing nurse or practicing respiratory therapist to manage more cases in the hospital at any given time. Next slide. The other thing we did, we heard a lot about commercial ambulance service availability and the need to make it more efficient to get a patient out of a hospital and back to a nursing home, for example. And sometimes transportation was the key. So we changed the requirements of what it takes to drive an ambulance from somebody that's medically qualified to somebody that basically is qualified to drive a taxi cab. They need a public service commission license. And because these are low acuity cases, and we felt like we had made our standard high in a way that assured people were safe, but maybe so high that we were encumbering the movement of patients when they needed to move the most. So 11 services so far have taken advantage of this. We've increased the availability of ambulance services in the state over the course of the last couple of months by more than 20%. And next slide. And finally, just in this last week, we created the Maryland Hospital Commercial Ambulance Request System, where hospitals can go online, alert every ambulance service at one time that they have a case, and the ambulance services bid on it, instead of making calls to multiple different ambulance services trying to find the one that will come the fastest. They do this all at once. I think that's the end. Next slide. Yep, I'm done. Thank you for your indulgence. I appreciate the opportunity.
It did. For the commercial ambulance request system. Do you have a sense of how frequently it's being utilized?
Well, so far the startup has been kind of slow. It's hampered in two ways. One is the expectation of hospitals is quite high, meaning they'll make one call and get an ambulance services. So we'll be there in an hour. And then they say, well, that's too long. I think I'll call a bunch of people. An hour is actually pretty good. If you're on one side of Baltimore and it's a routine call, to get to the other side of Baltimore in an hour isn't such a bad deal. But so there are some cases like that. The other thing that is a little bit of a hindrance is the way that Medicaid funds non-emergency ambulance transportation. And so I'll use Baltimore as an example again, but it's true of every jurisdiction in the state. That is handled not in the routine sort of fee for service kind of way. It's a grant that's provided to the local jurisdictional health department, who then contracts with a particular ambulance service. And so it really locks in the case to a specific ambulance service. So if they're delayed, they're delayed. And you can alert everybody to the fact that there's a delayed case, but the other ambulance services aren't going to jump in unless they know they're going to get paid. So some of the hospitals will just pay them just to make the patient move, and others not so much.
Thank you. Other questions for Ted?
Casey?
Hi, my name is Casey Boyer. I'm a commissioner, but I'm also on the city council in Havre de Grace. And our EMS has been, as you know, pulled to the very limits. Our biggest concern is being able to have ambulances on the street. And I'm very happy to hear about the HA system. How is this distributed out to the ambulance corps, and how is it being used? Is it new? How long has it been used?
Well, it's been out for several months as we amped up and tested it several different times. And really, in earnest, we've tried to advertise it to all the EMS clinicians over the course of the past couple of months. They see it when they log on to eMeds, their charting system. They get a notification that, it's basically an advertisement for AHA. We've distributed through what we call the highest jurisdictional officials. So basically the jurisdictional leaders in every EMS system have gotten it. It's been posted in newsletters that every EMS clinician gets, and it's on our website as a resource. And basically I forget the term, but it works as a website. And so if they go to it once, they get a queue to create a link that is lasting. It makes it look like an app on their phone or their computer, even though it's this dynamic website thing that's working in the background.
Okay, and so another challenge that we have is EMTs. multiple challenges there as far as not having enough, trying to recruit new, et cetera. The clinical externs was very interesting. Are nursing students also being used as EMTs in other parts of the state? And is
Not-
that
Yeah, not in any place in Maryland that I'm aware of. Although that's not an option that's been ruled out. It's just not been, it hasn't been proposed or discussed anyplace. And so when we created all those provisional EMS clinicians before the last state of emergency expired in August 15th, there were 1,200 EMTs who signed on as provisional folks. And we converted the majority of them to fully credentialed people. And I expect the same thing to happen now. We also, I didn't mention, we're trying to, well, we have a grant that we're waiting to receive the official notification for, that will provide a stipend for people to go to become EMTs so that we can incentivize more people to want to do it.
Thank you. And again, just reiterating here, from a rural perspective, when our ambulances go from Havre de Grace up to Bel Air, they're returned back to us at any point of the way. If there's a call that's in Bel Air or close to there, they get called off to do that, which makes it so we don't have ambulances within our community. So, and as much as we can do to support the ambulance corps around the state and get more personnel in positions, the better it is for the smaller towns and rural communities.
Absolutely.
Thank you.
Other questions for Ted? Thank you, Cassie. All right, Bob, you're up.
Thank you, Mr. Chair, Dr. Pollack, and commissioners. Good to see you all, and thank you for the invitation to be with you today. I also have lots of charts. Most of mine will be very different from Ted's. Before I get into the charts, I do want to say, early in the pandemic, Mhcc stepped up and started granting emergency certificates of need, and that was really helpful to our hospitals to expand capacity. And you've processed those quickly. You've extended most of those very willingly, and that response is much appreciated by our hospitals that have used that. I also, kind of moving to real time, I will put in a pitch a little bit that our hospital personnel are under extreme stress right now, and we've even got executives doing things like manning testing facilities, or I've had one executive tell me he's been mopping floors, you name it. So anything you all can do as a sometime regulator to ease the burden on our hospitals in terms of commanding their attention or data requests, things like that, will be much appreciated until things calm down a lot more. We can go on to the next slide, please. So some of my charts are going to look like some of Ted's, but there's many differences. So this shows hospitalization rate going back to July of 2020 per 100,000 population in Maryland in the green and the nation in the blue. And so while there's some tracking, what's most notable is what's happened in the last month, where we rapidly, with the Omicron variant, outpaced hospitalizations in the rest of the country. And that's what came close to putting us to the breaking point. So 51, we're now the 51 and the 46 are numbers valid as of yesterday. So we were in our ratio compared to the nation was worse just middle of last week. Keep going. Next slide, please. Another way we look at this is hospitalized. This is each bar is a state. So Maryland is the green. There's our 51 per 100,000, and you see where we stand. For most of the pandemic, we were kind of in the bottom 15 lowest. And this last wave has pushed us well above the national average. And the little dots there on the bottom show our neighboring states. So you see 4 of our adjoining states are in worse shape than we are. And of course, I'll highlight DC because DC gets a lot, about half the people occupying beds in DC come from out of DC. A large percentage of the out of DC are coming from Maryland. So a lot going on in our region, and we're fingers crossed that it's going to die down, but not in a good shape right now. Keep going. Next slide, please. So this is a little bit of a progression since the beginning of the pandemic. So just to orient you, the blue line is total COVID inpatients. The green is those in acute care, and the gray is in intensive care. And going all the way back to April of 2020, when we knew it was coming, the governor immediately called for a state of emergency. And by middle of April, he actually issued an order to halt all elective procedures in our hospitals. And that order stayed in place until the first week of June of that time. I just want to say the word electives is often misunderstood. It would, some people who frankly should know better think it's things like, plastic surgery, cosmetic surgery. Elective is simply a term that means can be scheduled, really. But many of these procedures can have life and death implications, or certainly bodily function implications. And so, we should not be thinking that it's easy to squeeze electives out. We hit 1,700. That first peak, we had 1,952 on January 11th of 2021, and we thought we were just overwhelmed at that time. I note vaccines arrived, and we're starting to go into the arms of hospital personnel on December 14th of 2020. And then with the arrival of vaccines, we thought, the end of the pandemic was in sight. And if you go up to June of 2021, it looked like, for the most part, we were trending downward, and everybody was high-fiving by the end of June and talking about having no COVID patients. Needless to say, that didn't last. The governor declared an end to the public health emergency at that time. And then you can see what happened after that. We had Delta, followed by Omicron. One thing you may note is that the percentage of patients who are in intensive care is down in this latest wave. There's a lot more higher percentage in acute care, but the acute care patients are acutely ill. Case mix index has risen throughout. And so, just the amount of effort that goes that goes into caring for each patient has really grown. Next slide, please. This is just a quick take on regions. So the blue here is the central region. The counties are identified there. And the green is the capital region. So central has been home, if you will, to about half of all the hospitalizations. Part of that is, of course, driven by the fact that our 2 academic medical centers, University of Maryland Medical Center and Johns Hopkins Hospital, are in Baltimore, and so we'll draw from around the state. Next slide will show the other 3 regions. So the scale is very different here. The top of the scale is 350, but you see that Western region in particular has had some serious spikes, both last January and this time around. But the other regions which have fewer people have also particularly been hit in this latest round. Sometimes I show charts on where people are most vaccinated. There has been a correlation between vaccination rates and hospitalizations, although lately with Omicron, that correlation has diminished somewhat. as I'm sure many of you know, a lot of people who are vaccinated are getting positive tests with Omicron. But I will put in a pitch to say vaccination and boosting is vital, and it certainly diminishes the intensity of any illness. And we in the hospital field, Maryland Hospital Association was the first hospital association in the country to come out stating that all hospital employees should be vaccinated, and we stick to that. Next slide, please. This is data from CRISP's dashboard, and what it shows is activities in statewide in hospitals, inpatient admissions at the top, and ED visits at the bottom. And so you see the pandemic starting, and it's activity compared to the 2019 base. Regardless of when on the same date in 2019 is the base for each point along as you go from left to right. So you can see when the pandemic started, governor's order to stop electives, and generally people just locked down, staying home, being afraid to go to hospitals. You see that huge dip, about 30% in inpatient and almost 50% in ED visits. And it's never fully gotten back to pre-pandemic levels, but don't be misled by that. That doesn't mean we've got a lot of free space in our hospitals, because A, we now have a tremendous workforce challenge, and B, as I mentioned, the intensity required for each patient has grown. So our hospitals are really very full. And so each admission is taking more resources, taking more time. We're also having, as I'll mention a little bit later, difficulty getting patients out of hospitals when they're ready for discharge medically, and that's also part of the clog that you're seeing that Ted described. And I just want to, by the way, a little note to say, I'm very, Ted gave a really great presentation, and Ted has been a tremendous partner. He's a model public servant, and really value his engagement and his solution finding throughout. Next slide, please. Okay, this is a little bit complicated, but it's something that I think MHCC would be interested in. So just to orient you, green is COVID patients, blue is non-COVID patients, gray is unoccupied staffed beds, and then the white is the remaining physical beds that are available but not staffed. So you see, we started out at the very beginning of the pandemic. We've added about 1,000 and maintained about 1,000 more physical beds. And then, we managed through much of the pandemic to maintain as many as 1,000 staffed available beds. That has gotten down to as few as about 300 in recent weeks, is now back up to 600. But staffing those beds is extremely difficult now. I'm sure you've heard all the stories about use of contract nurses, travel nurses, so to speak, overtime, double shifts, just tremendous effort going into and astounding amounts of spending to keep these beds staffed and available. And so you see that we've got 5,000 non-COVID patients in our hospitals. I'm going to show you something else that shows where it dipped, where it really squeezed. Go to the next slide, please. So this shows, again, trending all the way back. The gray line is just a retracing of the COVID inpatients. The blue line is unoccupied staffed acute beds, and the green is unoccupied staffed ICU beds. And you see a steady downward trend over the life of the pandemic. And this just talks about, again, the heavy burden that COVID is putting on the system, and the tremendous amount of demand for non-COVID care that we're still bearing in our hospitals. A lot of that was pent up demand that of services that were not there was delayed care. People, there were, you've heard that a lot of preventive care, mammograms and things like that didn't happen timely, and we're seeing the disease presentations as a result. So this is a continuing squeeze on our capacity. Next slide, please. And this is kind of I kind of call this the JAWS graph, because the COVID, it's green is COVID and blue is non-COVID for the whole time of the pandemic. And so you see we reached what was almost a low point ever since April of 2020 in only 4,342 non-COVID patients in our hospitals just about a week ago. There's been a little bit of relief, so we've been able to put about almost 700 more non-COVID patients back into beds. But this has been a real difficulty and a real strain. Next slide, please. This is a chart that my team just put together for the first time yesterday. This is the percentage of patients who in hospitals who are COVID patients for every state in the country. And so there we are on the far right. We have, what that means is Maryland has the highest percentage of COVID patients of any state in terms of beds in use. And you can kind of draw your own conclusions, but it's just another indication that the COVID burden has just been extraordinarily great in Maryland. Next slide, please. So I want to take a moment now and talk about crisis standards of care. You've heard that hospitals have been adopting crisis standards of care, and you may not know exactly who or what it means. And so this shows you the 15 hospitals in Maryland that are currently operating under crisis standards of care. And the first one to go was University of Maryland Upper Chesapeake there. And they went on December 24th. And the most recent to declare was Meritus Health up in Hagerstown that went on January 14th. So in the span of just 3 weeks, 15 hospitals went under crisis standards of care. Now you may ask, so this is 15, we've got about 44 acute care hospitals in the state. So this does not mean that the other 29 are doing just fine, thank you. They are just teetering on the edge. And it's, moving to crisis standards is a little bit subjective. I'll show you some of how that works in a second. But, those that haven't are certainly under extraordinary stress. And it may just be a few more beds used, as recently as 2 days ago in my board meeting, we heard from a number of hospitals that have their census is greater than their number of licensed beds. And so, this is a long way till we're out of the woods. So what does it mean to be in crisis standards of care? Let's go to the next slide. And this is my final slide. So the way it's characterized, and this is not something necessarily that's been made up here in Maryland, but it's kind of like 4 S's and 3 C's. So you look at your system overall, your space, your staff, your supplies, and then there's conventional standards, contingency standards, and crisis standards. And you can kind of see what the green column looks like. The goal in conventional and in contingency is to treat each patient optimally. When you move to crisis standards, you're treating the population of patients. You're not necessarily prioritizing the benefit of an individual patient. You're saying, how can we serve the community of patients that we have as best as possible? And so you're optimizing care based on risk profiling. And I'm not going to read you all these points, but in crisis standards, some of your systems are down. Possibly you're running under incident command rather than normal command and control. You're using unconventional space, not just ED boarding and hallways, but possibly conference space and offices. You're definitely canceling electives and delaying even urgent care. You're using non-traditional staff, so you're moving people into different units of the hospital where they're most needed. And you're getting help from outside, and this is where we have benefited from the public health emergency declaration to be able to bring in people from away and give them credentials. And you may be applying scarce resource allocation protocols. So back in the early days of the pandemic, when ventilators were scarce, we never actually launched scarce resource allocation protocols, but we were getting ready to do to answer the question of who gets a ventilator and who doesn't. Fortunately, we made it through that period, but there are some places where this is still at risk. So there are criteria that hospitals will use. We appreciate the good work of some leaders at University of Maryland Medical System and Johns Hopkins Medicine who kind of led the whole field in Maryland to define these and to kind of give everybody a standard. We do not have, as some states do, we have done at the state level, we do not have a governmentally specified mechanism for crisis standards of care. We can pull down the slides now, and I just want to make a few other comments, or you can leave the slides. But one thing, our biggest challenges, workforce is top challenge. It's always been a challenge in our hospitals. But right now, for example, to highlight that, we've got 3,900 vacancies in nursing positions in our hospitals. Those may be getting filled with contract travel nurses and so forth. The costs of labor are tremendous now because we're using so much contract labor. At the average cost of a nurse all in typically is about $50 an hour. We're now paying easily $120 an hour for travel nurses and up to $200 an hour. And we're using it in higher quantities. So hospitals are spending millions of dollars a month extra in paying people. They're also paying retention bonuses, have increased base wages and so forth. So these costs many of these costs are not going to go away. They're going to be permanent. And it's going to take a long time to restore the balance in our system. Even if COVID dips way low, we've got a lot of wounds to lick and to repair. We've got to restore the resiliency of our workforce. They've been battered. Retirements and leaving the profession or leaving the bedside. And the costs are going to be a long time coming until many of those costs will never go away. You heard Ted talk about psych capacity, that really extended ED boarding. That's been a real barrier. We don't have a lot of COVID positive psych beds in our acute care hospitals, and in our two psych hospitals, Shepherd Pratt and smaller hospital Brookline out in Hagerstown. They are regulated by local health departments in a different category than acute care hospitals, and so they've been put on outbreak status frequently. Anytime a patient or a staff member has COVID positive, they're very often required to close whole units, and that has dramatically cut our psych bed capacity. They're working that out with the health departments, but it's a continuing challenge. And they, of course, need help in being able to handle COVID positive psych patients because they're not normally equipped for that. And the third thing I'll just mention and final point is, handling transitions of care. It's all about, as Ted's comments suggest, it's so much about throughput, and any bottleneck anywhere in the system causes everything to back up. And so, one of the reasons for ED boarding is because there's no beds available. One of the reasons for no beds available is because we have patients who are ready to discharge who have no place to go. That may be because they need to go to a nursing facility, but the nursing facility won't take a COVID positive patient. Nursing facilities do have a lot of room right now, but they're being very, very, because of their staffing issues and other fears, they're being very, very careful about taking back their own residents back into their own care. And we've had issues of pre-authorizations by insurers of all stripes. We've gotten recently some help from, and we appreciate leadership by Care First on this, but most of the insurers and the Medicaid MCOs have eased up on prior authorizations, but it's a confusing soup of different policies and waivers. And so our hospitals are still struggling to figure out how to get patients moved to lower levels of care. So it's been a 2-year, it's not a marathon. It's been almost like a 2-year sprint. I'm really proud of what our hospitals have done, and certainly appreciate what the state, the efforts that the state has made to help respond. We get a lot of support and we have a lot of engagement with Secretary Schrader and his team. And so, I can't say we've gotten it all right at every step of the way, but we definitely get an A for effort here in Maryland. That's all I wanted to say. Happy to take questions.
Bob, a couple things. First, do you have any sense of the relative rate of premium labor utilization in Maryland versus other states in the country, and the relative cost of that? In other words, are we paying more on average per hour for labor now than other states, less, in the middle? How have we differentially been impacted?
It's a very fair question. Don't have good information. I attended a meeting of all my 50 state counterparts just about a month and a half ago, and everybody is talking about the cost of contract labor and the high use of contract labor. It kind of goes in waves. I mean, there was a period where other states didn't have as much demand, and really what's happened now is that, I don't know that we're worse off. We may be worse off at points in time like now, because we have a spike that has not hit other states at the same time. I don't have statistics on overall use of contract labor, but it's definitely 3 to 4 times higher than normal, and the rates are much higher. The costs are much higher. So it's there's talk of even at the federal level of looking into price gouging by the staffing agencies. They're certainly taking advantage. And one of the things that we're all seeing in every state is, whereas a travel nurse used to really mean packing a bag and going somewhere else. Now it's often you get hired by an agency and you get deployed across the street from where you just left. And so it's a really difficult situation to deal with.
And I see Ben's hand up, but just one other question before we go there. You showed a slide, I don't know if we can put it back up, that showed Maryland as number 50 in the nation, or 51, with regard to the percentage of COVID patients there.
That one there, yeah.
Yeah. And you sort of left it open to draw your own conclusions as to why. And I just wanted to ask directly, what when you look at what's different amongst Maryland with all those states, it's GBR. Can you comment on that?
Well, I think that I'm not ready to declare I know the answer, or even what I'm going to say is not to advocate, but to speculate. And that is to say, we manage capacity pretty aggressively in Maryland. I did a town hall for one of our congressmen last week and took a question. Somebody spoke up, a citizen who spoke up and said, I came from another state and I'm just astounded at how little emergency care capacity there is in where I am. And, of course, if you came from a place like Texas where there's a freestanding emergency room on every corner, too bad. But I think we manage capacity pretty aggressively here in Maryland, and that may explain it. And we've had a high COVID burden of late. This might not have looked as bad, at earlier points during the pandemic. This is a point in time as of a day or two ago.
Thank you. Ben?
Thank you, Bob. First off, I have a couple questions that Commissioner O'Connor asked. He can't get his speaker to work, so I'm going to ask them, and I have one of my own. His first question is for you, Bob, but maybe Ted can weigh in too, is do we have ways to test for different variants and appropriate mortality rates for different variants? And then a second part of that is, do we have a strict criteria for admission? And does it matter what variant a patient has on whether the patient is admitted? I think I know the answer is, but I'll let you know.
So in reverse order, no, it doesn't matter what variant a patient has. It's their symptoms and their medical need, and variant doesn't really drive that. Yes, we are, as far as strictness of admission criteria, not sure I understand. I mean, again, it's going to be the patient's acuity and the necessity of being admitted to a hospital bed, which is going to, again, be the decision of the doctor involved. We do appreciate that the insurers have come to recognize that, prior authorization is not, it's not like we're trying to fill beds at this point or really ever under our model. It's really just a question of choosing who's going to get to a bed first rather than who's going to get to a bed at all. Did I miss?
Yeah, I think that covered it. I mean, I think we're not testing, we don't have the capacity to do sequencing of every patient to make a determination.
Yeah, we're not sequencing at time of presentation. There's a lot of sequencing going on. Certainly our academic medical centers are doing a lot of that. The state is doing, state has some of the capability as well. So, we're learning, but it's a little bit more retrospective.
His second question is actually one I think the commissioners are interested in, because early on we created a framework under which anybody could go ahead and put up an overflow tent. Commissioner O'Connor says, how are hospitals using those overflow tents now? And could they potentially help, as they might require less personnel and less care for Omicron patients who need to be in the hospital, but obviously don't need it ICU as frequently, or even true acute care generally. Any thoughts on that?
Well, I mean, if somebody's in a hospital, somebody's entering a hospital, it's because they need at least acute care. Okay, that's what we are. We're in the acute care business. The problem we have is we have people whose acuity, they've been treated and they're ready for release, and we can't get them out, but we have to keep them in an acute care bed. One of the issues, for instance, we have is guardianship. There are people who, there's no guardian for them on discharge, and so we have to go to the courts and we have to wait with the courts for that. We are. I may have lost the thread of the question. What was the?
So it's how are overflow tents being used?
Oh, the overflow tents. Yeah, I mean they got used. They're mostly still up. Hospitals are using them. Probably a really good example of that is if you go to Fort Washington Medical Center, part of Adventist Healthcare now. That was a small hospital to begin with just like 4 ICU beds, and they've got it's not a tent, it's a rigid building that has essentially tripled their ICU capacity, and they are and others are using those. The notion that the patients with Omicron need less intensive, less acute care is somewhat false. If it's a question of the average versus what's yes, if you read what it says in the news, Omicron generally is less damaging, creates less illness overall, but every illness has a bell curve, and the sickest part of the Omicron wave is what's landing in the hospital. There's plenty of Omicron positive cases who are just getting mild symptoms and staying at home, but with so many people getting the virus now, you're still going to have that segment at the tail of the curve that are going to be very sick and need really serious care.
Thank you. And Dr. Bandari has a question. I can pass the floor to him. I have one other question, but I'll let Commissioner Bandari pose his question.
Commissioner Boyle was up also.
Okay.
Thank you, Ben, and thank you, Bob. Wonderful presentation. I just want to know, there must be a shortage of physicians also. I know a lot of nurses are either they are retiring or they are doing travel nursing. So one question is how we are going to handle physician shortage. I know in Annapolis area, almost 10-20% physicians are retiring, or they are going to retire, or they have cut back on the work. Secondly, have you seen same kind of increase in cost for the physicians' compensation? I'm not aware of that. I think as you mentioned, the nurses they are charging. I can tell you, I spoke to a nurse practitioner yesterday because I'm trying to hire an NP, and she said she wants to 150,000 to 200,000. And I say, my primary care physician just to graduate is starting at 150. So that's really a big cost difference. So if you can comment on that, that would be very helpful.
Sure, I'll try. I mean, you might want to talk to Mhcc, but physician shortage is a longstanding issue, and with the retirement wave of the baby boom generation, it's gonna be exacerbated. It hasn't, particularly since the early days of the pandemic. Physicians have not been the rate limiting factor, the bottleneck, if you will, in enabling us to care for COVID and all the other patients. They have been, stretched. We've had surgeons going in and doing medical care, for example, particularly when surgeries have been cut back. But we have not had a true shortage of MDs as regards handling the pandemic. That doesn't take away from your point that over the long term, we are going to have a shortage of physicians. And we also have a maldistribution of physicians, of course. And, some of the flexibilities that we were advocating for in terms of cross-boundary licensure, reciprocity, as well as the better uses of telehealth will allow us to extend the reach of physicians. We got some telehealth legislation passed. It was inspired by COVID, but it's been made, I don't want to say permanent because it has a sunset provision, but that helps spread our capacity into some areas of less access. But your base concern about numbers of physicians and proper compensation of physicians is a good one. I did see the governor's budget. He did say that Medicaid was going to start paying 100% Medicare rates under his budget, which should help. But it won't change numbers overnight.
Thank you.
Commissioner Boyle.
Hi, thank you for two great presentations. Bob, you partially answered it, but if you could elaborate on what you think the long-term solutions that Maryland could take on the staffing shortages in hospitals, particularly the nursing.
Yeah, well, we've at MHA, we've launched a healthcare workforce task force because, we know we've got a long-term problem to solve. And there are no easy answers, and my counterparts in other states are grappling with the same issues. We obviously have to figure out how we fill the pipeline. Interestingly, there's not actually a shortage of people interested in entering the nursing profession right now. There's a shortage of nurse educators. There's also a shortage of capacity in hospitals to provide the clinical clinical part of the training. So we have to figure out, we have to look at that pipeline. I had a conversation a couple of years, like three plus years ago, with Jay Perman when he was running the University of Maryland, Baltimore still. And, he talked about, needing to get to sixth graders to introduce them into the health occupations careers. And there is certainly some of that that's going on, but it's a long slog. We recently had some engagement with our workforce task force, met with the leaders of the Maryland community colleges to try to increase, their throughput. So we're going to have to look at this very strategically, and frankly, it's going to require investment. We can't. Hospitals can pay people, but we can't necessarily dig into our pockets to go into the high schools and provide all the education to get people on the track. So we have to recognize that our health professions in many respects are a public good and they need public support.
Commissioner Boyer.
Thank you. Thank you for this presentation. I'm getting a lot from it and I really appreciate it. But from the hospital point of view, given the information that you know now, and acknowledging not knowing what the potential impact of any emerging variant may be, or what impact it will have in the future, how comfortable are you today with the prospect of closing hospitals and going over to freestanding medical facilities?
Well, I can't give a generalized answer. I think we have parts of the state where we have more than ample inpatient capacity. Obviously, the pandemic has raised questions of, how much capacity do we need to keep permanently available for, truly once in a century occurrences, because there's a cost to that. Everybody understands that. And so, we have to learn. We have to, I think, invent some new models of flexibility. You guys are obviously looking at the maps, and where there appear to be high bed to population ratios and lower ones. And you have to obviously look at that in a nuanced way, because some of those beds are referral sites that are drawing from wider than their local population areas. So we in the hospital field are not, we don't have a kind of a blunt instrument that says, more beds is good, period. We know that the world is moving to more and more outpatient care, and technology is enabling that. It's not, things that can be done on an outpatient basis are things, Dr. Pollack's a orthopedic surgeon. He's seen massive shifts in what can be done in outpatient versus inpatient in that space, not to put him on the spot. So I hope that was a acceptable answer to your question. It requires a lot of discussion, and we'll be happy to come back and meet with commissioners and staff to talk about new ways of defining what's appropriate capacity.
Thank you.
Ben, you had one last follow-up.
Yeah, this is for Dr. Delbridge. And let me pull that up from Commissioner O'Connor. And this relates to your question on borders. He wanted to ask, what are the bottlenecks in the ER? Is it lack of staffing or just the sheer volume that's causing these buildups of borders? And again, I think you know the answer, but I'll pose it to you. What criteria are there to permit borders in an ED? Are you still there, Dr. Delbridge? He may have dropped off.
Yeah. So what was the question again, Ben, was regard to
What from Dr. O'Connor, this was, what are the causes for the bottlenecks in the ERs? Is it lack of staffing or patient volume?
yes.
Yeah,
I can answer.
well, you can go ahead, Dr. Pollack. If you
Let me
want to
try and Ben, Bob, you had it, but it's yes is the answer to that question. So it's the lack of staffing, which creates a lack of bed capacity on the floors sufficient to handle the volume coming through the ED. But it's really the borders are a result of a lack of bed capacity within the hospital. It's not physical bed capacity, as was shown in that slide. It's staff bed capacity, and the staff bed capacity is a function of the availability of the agency nursing, availability of the paid, the regular paid nursing, both of which have been dramatically impacted by this, as well as the volume of COVID positive patients coming in. Bob, did you have anything to add to that?
That's perfect.
And I had one question for Bob, that the commission staff has gotten a few letters from distressed nurses talking about the cruel choices between staying on as a salary employee versus joining the corps of nurses who work for agencies. Are you aware of any hospital strategies for retaining nurses given the opportunities that agency nursing offer?
Yeah, well, trying to, it's the agencies have had so much opportunity to offer huge pay, and they've started adding benefits. So it gets really hard to compete when somebody's being told, you can be paid the equivalent of $200,000 a year, to leave a job where you're getting paid $75,000, $80,000. And so, our hospitals are putting out retention bonuses. They're raising pay. They're increasing work, shift flexibility as much as possible. Increasing benefits. It's just everything and anything. Frankly, the money that's flowed in, money that the governor has granted and that HSCRC has granted, so much of that is just going to keeping hospitals in the bidding game to compete, because if we can't keep up, never mind, just within the state, people are going to leave and go elsewhere. And, hopefully this will die down. But, we've been going 2 years. We don't know when we can count on seeing that.
So I think there's still some more questions coming in, but I'm going to ask, I think we're going to have to cut this and allow people to reach out potentially to Bob and others in writing.
Sure. Here, I'll put my email right now into the chat, and then I'll get out of your way.
Obviously, we hit an interesting topic for the commissioners, to say the least, and I greatly appreciate Bob and Ted, your coming to join us today and sharing your experiences and the state of the situation with us.
Thank you, and thank you for your support.
Thank you. I want to move on to agenda item number 6 at this point. I believe, no, I'm sorry, agenda item number 5, our legislative update. Tracy DeShields, Director of Policy Development and External Affairs, will give us a legislative update and review the bills that are priority for the commission and bills that are coming up in the next weeks. Typically, we would have had a commission call this morning to review that. And initially, when our agenda seemed light, we decided to move it to the regular meeting. Tracy, the floor is yours.
Great, thank you. Good afternoon, Mr. Chair and Commissioners. Yes, I'm going to provide, and I'm going to make my presentation brief. Legislative update for you thus far. Next slide, please. The legislative session, as been stated earlier, began last Wednesday, January 12th, and we are actually on day 9. And I have to say that we are off to the races with regard to the legislative session. They have put in place certain protocols and guidelines for the session, both the House and the Senate. Next slide, please. In particular, these protocols are as a result, obviously, of COVID-19. The House, this legislative session will remain virtual for all bill hearings, budget hearings, and briefings. Which is actually sort of helpful because then everyone kind of knows where they need to be and where they don't need to be, I guess, with regard to the House as far as being in person. They are allowing or will allow at some point individuals to watch the floor proceedings from the gallery. Masks are required. And I'm not sure, last session, they sort of operated on a 2-hour time frame, like they would be 2 hours in at any one time, and then they'd have a break and then they'd come back. I believe they are still doing that for this legislative session. Next slide, please. The Senate, on the other hand, really was going to try to do things in person. It's fewer of them, and they were thinking that perhaps they could do that. So at this time, they are virtual for briefings and hearings until about February 11th. And then February 14th, they will go in person, which means there will be, they'll have live streaming of floor proceedings. I'm not sure about committee proceedings, but they will not be in a hybrid sort of stance where you could testify on a bill remotely or whatever. You have to be in person. They are going to continue with the online sign up of bills and things like that. So, so we'll see what happens February 11th with regard to the Senate. Next slide, please. So the key committees that MHCC has bills in or things that we weigh in on in the Senate committee, it's predominantly the Finance Committee and the Budget and Taxation Committee for our budget hearing and briefings. In the House of Delegates, it's the Health and Government Operations Committee and Appropriations. And I just want to take a moment to let the commission know that the committees that we engage in mostly, 3 of the chairs are women, and those 3 women have announced this year that they will not for re-election, that they're actually going to retire after this legislative session. And I just want to point out that it is astounding because I think between the 3 women, Senator Dolores Kelly, Delegate Shane Pendergrass, and Delegate Maggie McIntosh, they probably have spent their yeoman's lives in public service in the legislature. I think like, I don't know, 30 plus, almost 40 years, each of them. And they've been tremendous friends and advocates to the commission. And I think that was kind of worth noting today, that they will be missed, and they have really provided a lot, changed a lot of things for the better for all Marylanders as a result of their service as legislators to Maryland citizens. So I just wanted to, I felt like I needed to sort of recognize that because I noticed that today and I just thought that's absolutely astounding. Next slide, please. So generally, as I mentioned, the legislature started last Wednesday. Bill hearings began on that following Thursday, bill hearings and briefings, actually. Not very many. The things that they are scheduling right now are what they call pre-file bills. A lot of them are sometimes departmental bills. Not necessarily controversial, but maybe not as controversial bills that they're currently scheduling for bill hearings. Next slide, please. So this month in January, actually the other day, our sister commission, the HSCRC, they did a briefing on the total cost of care to the HGO. And then today in Senate Finance, they're doing one on hospital liability and the 2021 HSCRC report. And then we actually have a briefing regarding the development of the telehealth report that we're required to do as a result of legislation that passed on the telehealth bill last session, House Bill 123 and Senate Bill 3. Next Wednesday, the briefing will be held. And I don't know if Ben or David just wanted to make a couple of comments regarding that briefing or the status of the report. I think you did have an update by David earlier in the fall about the progress of the telehealth report at this point.
Good afternoon, commissioners. This is David Sharp. So I would just note that for Tracy's comment about the presentation to the HGO leadership, we plan to go over at a high level the requirements of the legislation from House Bill 123 and give a report on our progress in carrying out the study. Those are probably the two large elements of our presentation.
Thanks, David. Next slide, please. Great. So what we have coming up in February actually is our budget hearing. The first one will be in the House Appropriations Subcommittee on Health and Social Services. That is February 14th. And then that same week on Thursday, February 17th, there's a budget hearing for us in Senate Budget and Taxation Subcommittee, Health and Human Services. Next slide, please. So the priority bills for MHCC is that we have two bills in, and at the time that this slide was developed, we did not actually have bill numbers, but we do have bill numbers for these two bills. For our MHCC user fee assessment bill, the bill number is Senate Bill 253. And actually we have the Senate hearing is scheduled for next Wednesday, January 26th at 1:30 p.m. in Senate Finance. The second bill, Health Information Exchange Definition and Privacy Regulations, it's House Bill 213. And that has not yet been scheduled for a bill hearing. It will come up in the Health and Government Operations Committee. Likely, I would say it might be scheduled around the 1st of February, if not the last week in January, if it comes up. So those are our two main priority bills that we're obviously weighing in on with the support and everything like that. We were able to get Chair Dolores Kelly to sponsor our bill in the Senate, the user fee bill. And then in the House for our Health Information Exchange, Delegate Ariana Kelly is the sponsor of the bill. Next slide, please. Oh, that's the end. So moving forward, so we have had a lot of outreach of late on different topics, one on health literacy. There was by Delegate Paina Milnick, who may be putting in legislation around health literacy, which would certainly match sort of what we are doing with around health disparities. There's more bills, I believe, related to HIEs. And then we do have the advanced directives. If you recall the advanced directives work group report update that I gave last month, the official report will go out this week. And there is legislation. It is moving in both the House and the Senate. I'm not 100% sure, but there will likely be amendments, hopefully to align to the recommendations that came out of the work group that we did. So this would conclude my update for now. I think moving forward, because our next meeting is late February, we will likely have a legislative call with you commissioners to talk about upcoming positions on bills as they come forward.
I think people have Thursday morning times on their calendars held for that right now.
Yes.
So thank you, Tracy. It's good to have retiring senators when you need user fee increases.
Yes.
The question, Commissioner Boyer, I see your hand up and your camera off. Oh, that's a thumb up. Never mind. Sorry.
I was just trying to say, information received. Good job. Thank you.
Thank you.
Thank you.
All right. Any other questions for Tracy? Thank you, Tracy.
Thank you.
All right, on to agenda item number 6. The update on increasing public awareness of the Maryland Quality Reporting website. So as you know, the Commission maintains the Maryland Healthcare Quality Reporting consumer website in fulfillment of our mandate to increase transparency and informed decision-making among consumers and to facilitate improvements in the delivery of care in Maryland. Increasing public awareness of the website continues to be a priority, as well as a challenge for the Commission staff. Sumitra McCammon, Program Manager within the Center for Quality Measurement and Reporting, will provide an update on efforts to increase awareness of this important resource. Sumitra, the floor is yours.
Thank you. Good afternoon, Commissioners. Next slide, please. Today, I would like to give a brief overview of the Maryland Quality Reporting website and staff activities to promote the website since its relaunch earlier last year. Next slide, please. The Maryland Quality Reporting website is designed to facilitate informed decision-making among consumers through the public reporting of healthcare quality and cost information. The website includes data from Maryland hospitals, nursing homes, home health agencies, hospices, commercial health plans, adult medical daycare centers, assisted living facilities, and outpatient surgery centers. In 2020, the center embarked on a website redesign where we held 4 90-minute focus group sessions with Marylanders who plan to or had recently made a long-term healthcare decision. The final website design that you see here combines 4 previous websites into one easy-to-access, consumer-friendly website. Users now have fewer clicks to reach the information that they want and need. Since our website relaunch, we have had over 16,000 users, an average of 2,000 per month, and 37,000 page views. In addition, females represent nearly 64% of our website traffic, and consumers ages 25 to 44 represent 40% of our website traffic. Next slide, please. Website promotion is a constant in our center. Our current promotional strategy includes social media posts, guest blogs, custom promotional toolkits, stakeholder collaborations, staff presentations, and paid advertising campaigns. We have several new promotional strategies that I will talk about over the next several slides. Some of them are highlighted here in red. They include the Maryland Public Television campaign, establishing a Nextdoor account, and stakeholder collaborations with AARP Maryland, Maryland 211, and Baltimore County Libraries. We also recently released our long-term care planning toolkit section to the website. Next slide, please. The center began working with Maryland Public Television in June of 2021 to launch a promotional campaign. This campaign will target minorities, patients, and caregivers, and highlight the long-term care resources on our website. The campaign will be released in 3 segments over a 6-month period to continuously engage consumers and maintain consumer interest. The campaign will include social media and digital advertising on outlets such as Google Ads and Facebook, print advertising, video public service announcements on cable and public television, and audio public service announcements on digital and commercial radio stations such as Maryland HBCU radio stations, Pandora, or Sirius XM. Next slide, please. Now we will review a 30-second media clip for the television and radio ads. This clip may look familiar to some of you. To maximize our resources, we repurposed our media asset from our 2019 movie theater campaign. Can you please play the clip?
Making complicated healthcare decisions for the ones we love can feel overwhelming. The Maryland Healthcare Commission is here to help. It's a state agency whose mission includes helping you make informed healthcare choices. The Mhcc website allows you to review and compare options like assisted living, nursing homes, and hospitals. These aren't easy decisions, but it's better to be prepared. To learn more, visit healthcarequality.mhcc.maryland.gov.
Next slide, please. In the spring of 2021, House Bill 599 was passed, and it required the Commission to create a long-term care planning guide for Maryland residents. The planning guide is a part of a new, larger, long-term care planning toolkit section on our website that you see here. Next slide, please. The one before that. Uh-oh. The toolkit's landing page is displayed using 5 tiles that mimic our homepage design. The checklist tile offers printable checklists to help users choose a nursing home, hospice, assisted living facility, or home health agency. Under the guides tile, we have included a short printable documents with information about long-term care services, such as understanding hospice care, or services available in the community. The Advanced Directives tile includes a fact sheet and a link to My Directives so that users can immediately begin their planning process. Finally, we included a financial planning calculator because during our focus groups, we learned that cost is a priority for people planning for long-term care. Next slide, please. The long-term care planning guide is downloadable, printable, and will be available to consumers in English and in Spanish. This guide is found under the long-term care toolkit tile. Next slide. Next slide. Thank you. Social media is one of the primary methods the center uses to communicate information with Marylanders. Center staff posts using the Maryland Healthcare Commission's social media accounts. Staff have done tremendous work to increase efforts to promote the website on social media. Some of these efforts include posting new customized content daily that is specific to the respective social media platforms, to post content during peak engagement times using our content scheduler Hootsuite, to make images to accompany the content that reflect the commissions and website branding, and to use the polling features to engage our consumers on applicable platforms. Consumer engagement varies by social media platform. Facebook and Nextdoor refer the most consumers to the website, but consumers engage more with content on Twitter by doing things like liking and retweeting our content. On the left, you will see some of our sample social media posts from our various platforms. And on the right, you see some of the recognition that the Commission has received from organizations such as the Maryland Department of Aging, the Image Center, and WMAR's TV 11 News. Most recently, the Department of Aging posted, "Maryland Quality Reporting is another resource for information on the quality and performance of nursing homes, hospitals, hospice, assisted living, and more." And the Image Center shared, "The Maryland Healthcare Commission provides information to the public about the availability of healthcare services for various needs." These comments highlight our increasing recognition as a trusted source of quality and cost information in Maryland on these platforms. Next slide, please. In July of 2021, the center began collaborating with AARP Maryland because of our mutual desire to share relevant aging content with the 55 and up demographic. This partnership allows the center to share content with approximately 800,000 members. To date, the center has done one guest blog, and potential future opportunities for collaboration include doing a town hall presentation, collaborating on social media by sharing posts and content with our respective viewerships, participate in some of their monthly volunteer calls, and adding the Maryland Quality Reporting website as a resource to AARP's Prepare to Care Guide. Next slide, please. In August, staff collaborated with our colleagues in the Center for Health Information and Technology to do a joint presentation with Baltimore County Libraries. The goal of this presentation was to share resources on telehealth and healthcare quality reporting with the hopes of reaching more vulnerable populations within the county. Staff presented to 20 librarians who could then share the information with consumers. We received positive feedback from the presentation and hope to continue this partnership by expanding it to other county library systems and to share print materials like our hospice brochure and infographic that we will discuss on the next slide. Next slide, please. In 2020, the center developed a hospice brochure and infographic to increase minorities' awareness of hospice benefits. The pandemic delayed distribution, and staff used innovative strategies to overcome the challenges with dissemination amid the pandemic and a website redesign. Staff were able to share the hospice brochure with 8 county libraries with the highest proportion of African Americans and hospital discharge planners who requested the information. Staff also updated the infographic shown here on the far right to reflect the look and feel of the new website brand. We did this so that we could continue to share this information on social media and plan to update the brochure with a similar theme later this year. Next slide, please. In September of 2021, the center created a Nextdoor account. This platform is like Facebook, but it's organized by neighborhoods and allows the center to geo-target content. Nextdoor also gives the center access to nearly 1.2 million members who follow the Maryland Department of Health and the unique ability to gather real-time feedback on website content and usability using the polling functionality. Illustrated here are some examples of our Nextdoor polls where you can see polling results, the respondents' neighborhood, and their comments. Since creating this account, the Center's Nextdoor content has resulted in over 93,000 impressions, 270 votes, and 29 users being referred to the website with just 3 posts. This makes Nextdoor an ideal platform for increasing visibility and direct engagement with consumers. Next slide, please. Maryland 211 is a nonprofit who connects Marylanders with health and human services. In October, center staff worked with Maryland 211 to update the resource information that directed consumers to the Maryland Quality Reporting website. These updates resulted in 29 users being referred to the website and Maryland 211 becoming one of our top 10 referring websites. Next slide, please. We never stop promoting, but some of our next steps include to launch our pending Maryland Public Television campaign next month, to establish partnerships with Good Day Maryland and the Maryland Department of Transportation, to expand our community outreach by launching our barbershop and hair salon campaign, and to have staff return to attending booths at health fairs like the annual Senior Expo whenever possible. We would also like to expand our reach on social media platforms and expand our existing partnerships with organizations like AARP Maryland, the county library systems, hospital discharge planners, and social workers. Next slide, please. Lastly, we would like to invite all of you guys to help. 3 ways that you can help Marylanders learn about the Maryland Quality Reporting website is to find, like, follow, and share our social media posts and pages, to give a poster to your local restaurant, barbershop, or hair salon, or mailing center, and to tell your family, friends, and colleagues. If you would like to access any of our promotional materials, like the flyer that you see here from one of our stakeholder promotional toolkits, please reach out to us. We would also like to thank our colleagues in the Center for Health Information and Technology for so graciously sharing their contacts and collaborating with us over the last year. Thank you for your time, and I'm happy to answer any questions.
Questions for Sumitra? I think this is a very valuable presentation for commissioners. It really highlights the amount of work that we're doing to try and get this word out to the public. Commissioner Boyle.
Hi, thank you. Great presentation. A lot of good work being done. Would you email us the information from the How Can You Help? So we have some of that, and left to our own devices, some of us may forget or get involved in the things, but yeah, send it to us and put it in front of us. That would be great.
Sure, absolutely.
Thank you.
Great. Thank you very much.
Thank you.
Commissioners will remember that in November, we held a strategic planning retreat aimed at setting Healthcare Commission priorities over the next 4 years. I've asked Ben to review the key themes developed during the retreat with the commissioners today. Ben will introduce each of the 5 themes, and then I'll invite commissioners to comment at the conclusion. Amy Langley with Health Management Associates, our strategic planning consultant, will provide an overview of the next steps in the planning effort. Ben, please proceed.
Thank you, Dr. Pollack. And what I will do is we'd like to spend about a half an hour on this today. The effort is to rekindle some of the discussion we had on the 19th of November at the retreat. I'll kind of outline the 5 major themes, and I'll also ask our consultant and Langley to comment, and then we'll get some additional feedback from commissioners. Overall, there are 5 themes. 2 of those themes focus specifically on our state health plan and CON activities. The others covered our broader responsibilities. The first one, which was a theme that percolated throughout the entire meeting, was to create a visible, impactful state health equity report card that focused on our broad areas of authority, including access, quality, outcomes, patient experience, and I probably would add cost as well. The emphasis is well anchored in the responsibilities of the commission. As was noted during the retreat, equity is a priority area for the state overall, and MHCC is recognized as a source of unbiased information. We do think we have tools to generate an equity report and are well aligned with efforts through the State Integrated Health Improvement Strategy, SIHIS, that can be aligned with the equity efforts. The challenges are a report is really needs to be most importantly relevant and timely to all of the populations that we focus on, not only minority populations, but more isolated rural communities. And the question is how broadly we would engage such a report initially. It was pointed out that we had models already in place in the state, including the Diabetes Action Plan and previous efforts to develop equity report cards in the state launched by the Office of Minority Health and Health Disparities. They certainly, along with the new Equity Commission, would play a role and key to establishing such an effort is for the commission working with its partners to decide what the primacy of MHCC's role versus the other organizations. The Maryland Office of Minority Health and Health Disparities, their principal function is health equity, and the new commission, the Shirley Nathan Pulliam Equity Commission, brings together all of the cabinet heads to talk broadly about statewide efforts to further health equity in the state. So I think there's some need for important coordination, but I think that MHCC has a longstanding responsibility in this area. There are some examples that we've identified in other states where a equity report card has been developed, but certainly building collaboration among partners is going to be a key element for moving forward. I'll pause here and ask Anne to add further comments from the perspective of our consultant.
Hi, thanks, Ben. I just, remind everybody that equity came up throughout the retreat. While the report card is a specific thing that the commission could do, and I think it plays to the commission's strengths, has been said. I also think equity, it was mentioned in the context of many of the other themes that came up, and that's just something I would say to keep in mind, that there are specific things within equity that you all, the commission can really contribute, but it's also a way that the commission could bring, it's a perspective you could bring into some of your other responsibilities already. And while we're on equity, I just want to echo Commissioner Sargent's words at the end of the retreat, which are, I'm paraphrasing, Commissioner Sargent. Equity is a big topic. You know, we can sort of bite out, you know, it's too big, but we don't want to focus too small. We're looking for that place in the middle. And I think that that's sort of also what Ben was referring to with the coordination with the other state entities that are really focused on equity, but really look for the commission's piece, the piece that's really, you all are uniquely suited to contribute and can coordinate with the other groups. I think that's my comments on that theme.
Thanks, Ann. Comments from commissioners?
You made me sound better than I sounded at the retreat, I think.
So let's move on. I think equity, you're going to see equity is going to percolate throughout all of these key themes. I don't call them priorities yet. I keep identify them as precursors to priorities, but clearly you're going to see this again. If we can move to the second area, which I've grouped into themes focused around the state health plan and certificate of need initiatives. And we can jump to the first one, which is this was echoed by some of our presenters on Friday the 19th, and it was transform the state health plan into a real state health plan. As Paul has told you many times, when we talk about the state health plan and there are multiple chapters, it is actually a state health plan for facilities and services. And its origin goes back to the 1970s when the discipline of planning really took root. Certainly it has evolved over the years in Maryland, and we've tied it to other state priorities, certainly over the last decade, to link it very closely to the evolution of the state's hospital model. But there's thoughts that we could think even more broadly, and a new state health plan could potentially integrate existing planning functions, focusing on hospital nursing homes and certain long-term care services, with other efforts that focus on supporting increased equity, success of the total cost of care model, improving outcomes, and reducing overall cost in the system as priorities of a modernized state health plan. It would focus on making the state health plan, and I think we should emphasize the state health plan chapters, more dynamic and particularly tied to other state priorities, as well as take some efforts to revitalize what has been a long-standing effort in the state, which has a name very similar to the state health plan for facilities and services, but is the state health improvement plan, which is localized initiatives that set improvement objectives for local jurisdictions. There's never been an attempt to align the two, but I think as we thought about this since the retreat, it does seem to me that we reflect on how we could use some of the decisions that are made at local levels in terms of their improvement priorities, in terms of better aligning the state health plan that we're responsible for developing with what are recognized local needs. There are considerations as we talk about modernizing or expanding the state health plan, is that we recognize that it is very specific and focused on services that would be subject to a certificate of need process. And it may be as part of this process that we consider realigning the state health plan to eliminate certain types of services that don't necessarily fit well with the broader objectives of establishing broad health improvement priorities. I'll pause here and ask Anne, who has experience from the standpoint of a practitioner of a planning effort from the perspective of Johns Hopkins, to comment.
Yes, but here on behalf of MHA, but you all know that I have more experience in this area. And I think Ben sort of touched on kind of the balance here. Drs. Benjamin and Mr. Colmers were really, really pushing for a pretty innovative approach to this, if in our state, to really push the state health plan to be sort of radically different. They were pushing for something that I think would be, it would be real challenging to do in the short term. But I think Ben's, it's great to notice that there are ways that those local initiatives, like those that kind of are observed through the State Health Improvement Plan, could be incorporated into some of the efforts with the CON process. I think that is a good balance between kind of the, totally radical, completely redoing the state health plan versus, keeping it. I don't think there are many people that understand the sort of the origins of the health facilities and services plans in the 70s, like Paul really understands. And I do think finding points within the state health plan, like using CON decisions or granting CONs as an opportunity to ask applicants to address the localized initiatives more specifically in what they are able to offer. I personally, I did some work in DC in the DC agency, which is very different from Maryland in lots of ways, but they do make much more specific requests of hospitals who are granted certificates of need for projects to give back to communities in need in more specific ways. And I think that's where the State Health Improvement Plan and the CON process in Maryland might come together. So that's just a little bit of food for thought for the state health plan theme that came out in the retreat.
Any questions, comments from commissioners?
Are we being aggressive enough with this revision of the state health plan? I mean, I hear us saying that we don't want to, we want to balance things, but I'm still not sure I understand the need to continue to control bed capacity in the way that we're doing it, given where we are with regard to the total cost of care model and the GBR model. The state's no longer on the hook for bed capacity when we develop it necessarily. The hospitals are. The rate control system is dramatically different than it was in the 70s. Yet our approach to this really hasn't dramatically changed. And I wonder if it's antiquated. And I wonder if what we just saw in terms of bed capacity statewide around the pandemic isn't isn't a sign of that, right? That we've sort of missed the boat in many ways in terms of projecting bed capacity. I think people would say that in Prince George's County, we're way off the mark in what actual bed capacity is, and that our measures of predicting it probably aren't accurate, and that what we're trying to protect is probably not relevant anymore. And when we do this, when we restrict bed capacity in certain areas, it disproportionately affects certain populations in a negative way. So I guess the question is, should we put everything on the table here when it comes to the state health plan and bed capacity? And I really like the idea of leveraging what we have to develop the types of programs that are necessary to really have an impact on equity and population health delivery. Maybe we could do even more in that direction.
Well, I think that's a good point that, would, if we looked at using Prince George's County as the example again, if we looked at bed need based on equity issues, would we come up with a different answer on the amount of capacity needed? I can't say that specifically today, but I think that's where you're going. Are you not?
Yeah. Yeah, I agree. And we don't necessarily have to live with it, right? It's the patient population in that area that lives with our decisions in those areas, and our restrictions. And I think that if we loosen things up, or if we let local factors make the decision with regard to bed capacity, didn't try and intervene as dramatically there, and instead said that we're not going to necessarily make decisions on bed capacity, but we're going to say that if you want X number of beds, I'm making stuff up here right now, if you want X number of beds, you have to have X number of additional resources in place for populations that will potentially decrease bed need going forward. In other words, doing what DC has done and linking more of the requirement for population health infrastructure with the privilege of providing inpatient care.
Other thoughts from commissioners? The goal here is to rekindle some of the thought that was going on in November, as we begin to go through the next steps of planning for our priorities, and certainly welcome other people's thoughts.
I think you had your hand up.
Hey, thank you. I don't know how well this fits into our mission, but given the presentations we had earlier and the kind of the crisis of enough staffing in our healthcare facilities, not just the hospitals, but the long-term care facilities, clinics, et cetera. In all of the key themes, there's no mention of staffing, and I question whether that's something that we need to include, because how are you going to have quality care if you don't have the proper staffing?
Other comments?
Go ahead, Commissioner Sargent.
I was going to say, it raises an interesting problem to me, because I think we can see the limitations of CLN in today's day and age, and a state health plan based around it. It's sort of, I've always thought humans are often better at diagnosing the problems than solutions. So we can all agree on the problem and then fight vociferously for whether any of the solutions will work. And I think we're sort of at that range here. For me, approaching the different things we might do, it's almost like we need a theme, because the first thing we say, this is what we want to do we have the authority? Is somebody else already doing it? Do we need to go to the legislature to do that? And do we fit within the existing regulatory scheme? It's hard for me to parse all of those at that very high level, right? So I don't have as much instructive to say as if we narrow it down to a particular area or a gap to envision the role, like our role as it fits in the existing state system, and whether it would be within our existing authority or something we would need to pursue legislatively first.
Agreed. And this is aspirational, or a broad priority that we're not trying to make a great leap forward in the span of a year or a legislative session, but elements of it would involve some statutory changes. I absolutely agree. Well, this is the direction we want to move our plan in.
It is one possible, this is just almost a process suggestion for us to identify couple specific areas, and then next look to, great, this is an area within healthcare that we want to focus on. Then the next step is, where would we fit within the existing scheme? Like, what would we do that somebody else is not doing? Or, you know, if we narrowed it down to a couple of areas collectively, that might make that an easier analysis.
Commissioner Gordon.
Thanks. Actually, I would agree with Randy's comment there. I think we can't do it all, but I sure think we could do a lot that needs to be done. And you know, we obviously can't do it alone. The cost commission, especially as it relates to hospitals, is a critical element. Maybe not as critical for other pieces of the system, but you know, I think a think tank or a work group or something that would, you know, say, what is the state health plan per se, and how do we impact it, and what could we do, would be a great thing. You know, I was around when the cost commission was born and things of that nature, and things have evolved. You know, my sense is that, you know, we're at a point where in so many aspects of this country, and certainly in healthcare, where if we really wanted to do something positive, we just might be able to do it in a very effective way, as opposed to the routine of what seems to happen just year after year. But that's my observation, you know, from a sort of an outsider now on the other side. Thanks.
Dr. Quintada.
Yeah, thank you. And I also just wanted to lend my voice to Commissioner Boyle's comment. We at the University of Maryland School of Nursing were recipients of the governor's mandate also, with trying to support healthcare organizations with nurses who could contribute to caring for the state. And we instituted an early exit program that you know, required that we evaluate our curriculum to identify our students who could graduate early, you know, still meeting all the necessary competencies. And we did this, I think the very first time we did this was the spring semester, which would be probably May of 2020, and we've done it several times. And now, working with our clinical partners, we recognize that, you know, if we evaluate those graduates from then till now, lots of them actually didn't stay for several different reasons, and lots of it, you know, has to do with the pandemic. You know, so we're losing staff in so many different ways, and there's been a tremendous amount of pressure, even sort of falling the domino back to the health sciences programs that graduate students. So I feel that has to be part of the conversation somewhat. I posted a question earlier asking how we could strengthen academic practice partnerships for clinical placements, even though that's just one factor, you know, that's increasing or that's one factor that stands in our way of increasing numbers of nursing students. I know at Maryland, but it's a significant issue. Once again, I don't know if we have the power to, you know, to do anything about that, but at the same time, I think we have a platform to be able to bring enough attention to some of these issues and hopefully be part of that discussion.
So on the staffing issues, I think there is a question about who is responsible. There are a number of different agencies within the department that have some role. HSCRC has a nurse financing program that allows them to fund a nursing program for hospitals. But the question that you raised, if you really want to have a real state health plan, the human resources element is the key ingredient of it. I don't think that we necessarily are the only ones that that would play a role there, but it is a key component if you're really talking about capacity and talking about addressing equity issues. To think that you can ignore staffing and human resources. If we can jump to the second area, recognizing that this is really the adjunct to the first one, which is make the CON program more of a tool to achieve other goals such as health equity. And that really complements what we're talking about in what was talked about on the 19th of making the entire health planning function more of a tool to address broader health system needs. Points that Anne mentioned in the district would be something we would consider activating here, which is linking, for example, CON awards, specifically conditions to achieving SIHIS goals. Those include SIHIS goals are reductions in diabetes, maternal and infant mortality, opioid deaths are three key SIHIS goals going forward, but there will be more. And also use an applicant's progress on achieving health equity in consideration of whether that CON need could be awarded. Again, not within the scope of the criteria or standards in our plans directly today, but that it is an idea to make that a component of the review process. This would require minimally regulatory changes on those chapters. If not, perhaps statutory changes as well. How that would work would be conditions could be placed on the awards that would help achieve alignment of local needs. Again, talking about this local health and the local health improvement plan, aligning that with what our community needs with a CON. Again, statutory changes are probably going to be needed. Minimally regulatory changes are essential. But these are clearly during the priority setting process, continued work on CON and health planning was a key emphasis of the commission.
Ben, are there areas where the state health plan, as we currently implement it, would say there is no need for a service, but there are populations within that same region who are just not being served because that service is practically not accessible for them? And if that's true, are there ways that we would be able to demonstrate that?
I'm not sure if Paul has his microphone on, but I'd yield to him to.
Good afternoon. Can everyone hear me?
Yes.
Yeah.
Randy, I think from my perspective, because I've been working on kind of redirecting the state health plan and updating the state health plan, there actually has been a major shift in the way those regulations function from, kind of being what I would call dumb standards that say, here's the bed to population ratio among different areas of Maryland, and using that as kind of a blunt instrument for basically locking out opportunities for people to even come forward with, capital investment plans for the commission to consider and act on. I can be convinced some days that was a mistake when we get certain types of projects to review. There's something very stable about setting bars that people have to confront even to come forward with plans. So and I could lay this out. I think most commissioners come and go over a time period where they don't realize that there's been this kind of big shift in a number of regulations in that area. But that's actually occurred in Maryland. So we're much less rigid about what we will take in and consider. And I think that's a good thing. But certainly there are, if the other part of your question, as I interpreted it, there's certainly a lot of resources and capacities that we regulate, because that's what the statute establishes as the scope of our regulation. And use rates have been declining. Hospital beds are, a good example. Setting aside what we see in terms of difficulties in the way capacity use fluctuates, and we've seen that dramatically in the hospital area in the last couple of years. Over the long term, we've seen really dramatic declines in admission rates to hospitals. That's why we have now 5 hospitals in the last few years that are basically stopping inpatient care and converting to outpatient care. So there are real demand and trend issues that we look at that say, there isn't really much sense or much need for additional service capacity in a lot of the areas we regulate. I don't know if that gives you any sort of response to your question.
Yeah.
Go ahead, Randy.
No, I was just going to say thank you. It kind of came out like a frog the first time.
Let's move on to the fourth theme that came up. And this is in response to recognized kind of flaws in data systems, make data resources more timely, more integrated, relevant, and usable to consumers. We in Maryland, in general, and the Healthcare Commission in particular, we have a relatively strong data infrastructure. If I repeated what the Healthcare Commission alone and what the state as a corporate entity collected, I think most other states would be extremely impressed. And then we take into consideration what we've been able to develop by establishing the state HIE CRISP over the last decade. We also recognize that reporting, we are a trusted source for quality. As you heard earlier from Sumitria, we want to broaden that, but there are issues with timeliness, accessibility, relevance, and meaningfulness of data. Consumer engagement is difficult, whether we talk with our colleagues at the federal level or in other states, or even at the provider level. Encouraging consumers to become more effective purchasers of healthcare is a big challenge. As we think about this theme, I think we need to consider simply having more consumers access our information is not necessarily an objective that we're going to achieve, but rather making information available to people when they need it may be a better objective than to say we have now, we've moved from 3,000 visitors on our quality websites per month to 100,000 is probably not meaningful. But if we instead said of the 3,000 that visited our site, we want them to spend 10 minutes on the site as opposed to 2 minutes as they do now, to really enable them to study the information and to use the information to help them make thoughtful decisions. I think we're moving in the right direction. We're never going to compete with a broad consumer website, but we need to focus on making information more relevant and timely and accessible for people who need it and want to take the time to access it. That's my feeling. And Teresa, I've talked about this as well as Mahi, about simply growing the volume of users. If those users only simply stop by, is probably not as beneficial as having a group of users who really learn something from our sites, but are a smaller number of visitors. So, that's what I would say in terms of my broad vision is making the information more relevant and useful to us, to a set of users who have the desire to make it important in a healthcare decision-making framework. And do you have any comments?
I would just say, this also, in addition to the state health plan, was an area that Dr. Benjamin and Mr. Colmers both emphasized. And I think part of that's because it is true in general across the country, access to more timely, transparent data is helpful to consumers. I guess something for us to think about moving forward as we sort of polish these themes is, is there a specific area that the commission would want to focus on within this theme, or how does it fit with the theme that we're about to get to, which has to do with more consumer engagement or with equity? I think we've really described here what the situation is in Maryland, and I'm not sure, we can do more to kind of develop where you might want to go with that. But I don't know if anybody has comments now about more specific than, as Ben has outlined, areas where you would like to see the commission focus with respect to data.
I think Dr. Akintada has his hand up.
Yes, go ahead.
Sorry, that may be from earlier.
And this is Dr. Bhandari. I have just a question. Is the data reporting or sharing data on the CRISP is mandatory or it's voluntary? Because the reason is I came to know from my colleagues, some of the radiology big facilities are not sharing data on the CRISP, so they cannot compare the scans or other things. Is it mandatory or it's a voluntary? Any agency can opt in or opt out? Because those radiology facilities are big ones. They are national level and they are advanced radiology is one of them.
These are radiology.
Yeah, radiology facilities. Advanced radiology is all over the state of Maryland. Actually, it's a company owned by the Redneck, which is a national. So they don't share their images and other things with the CRISP. That's, if they can share, that will be easy for the patient care. Any physician can access, when they go to the hospital, they can look at it. Will limit the duplication of the procedure and improve the quality of care also.
David's worked directly with the imaging initiatives at CRISP. David, do you have anything to add? But I don't think that that's mandatory for practices. It is mandatory for hospitals, but not for physician practices. But imaging is a special situation that CRISP has put a lot of energy into making images accessible. David, are you able to comment?
Yeah, I think you're right on point, Ben. I would say I have nothing additional to note other than the remarks you've made here.
So they don't have to report to CRISP because it's a quite inconvenience for the
They do
for
not,
the patient?
practices are not required to share information through CRISP at the present time. I mean, that is a question that I suppose, could be addressed through changes in the statute. I think the Healthcare Commission and perhaps even CRISP have argued that you have to make a use case, putting someone in a hammerlock, so to speak, to do that is not necessarily going to yield the success that we.
And I would note that practices are required to use CRISP only for consulting the prescription drug monitoring status of patients.
But David, these are radiology practices are big. They are not like mom pop shops. They're the big national company owned many of those.
So I apologize, I didn't hear your comments.
I said these practices, radiology facilities are big facilities. These are not small mom pop shops.
That is
they
correct.
Have like national level, they have presence at the national level and very much at the Maryland state level.
That's correct.
And other comments? The more timely is actually the easiest thing to achieve among these objectives. I think we can make progress on more timely data, but the challenges are certainly more usable for consumers. We need to think carefully about what that might be. National organizations, we have more than 300 quality metrics that have been developed, but I think most people would confess that we've made progress, but they are not yet drawing consumers fully into the whole quality framework that enormous amounts of energy have been put forth over the last decade and a half. Let's move to the fifth one. And I think this is something we've talked about, develop mechanisms to achieve and facilitate consumer and community engagement. This is something that many over the last decade, commissioners have talked about in making MHCC more consumer centered. I know that several commissioners during the retreat talked about, and in December said, well, did we get consumer input? And while we do put a priority on that, I think it's also fair to say that we are part of the infrastructure, the state health infrastructure in Maryland that is very much focused on the deliverers of healthcare and have been less successful in touching individual consumers directly. That's a challenging endeavor to undertake, but one in which I think we recognize as we move to a more patient-focused healthcare system that some are going to have to take on. Some of our advantages, we've talked about MHCC being a trusted source. We do have an existing consumer orientation. Unlike some organizations, we have specific consumer representatives that are identified in commission membership, and increasingly health priorities that have risen to the fore recently, particularly equity, make it extremely important that we engage the community more directly in these initiatives.
So I would just follow up on that because I think this is a big question for the commission to consider. Community engagement, the way some people would define it, is it's a big topic. It would be a big undertaking to really develop the capacity to do that well. Dr. Nilesh, haven't gotten good at saying his last name yet, health officer from Anne Arundel County, his description of their efforts, that county's efforts through the pandemic to address equity, I think gives lots of good examples of consumer engagement, which is easier at a local level than at a state level. So just different things for the commission to consider. I would also say the HSCRC has a specific function within the community benefit that is consumer focused. It addresses a much narrower area than I think it came out in this theme from the retreat, but it's also something to think about in terms of coordinating or collaborating on efforts.
I just, one comment about the Anne Arundel County example, which I thought was extremely instructive, but maybe I didn't get the same message out of it that other people did. I thought the cost effectiveness of that effort was very poor, and might be an example of something that was tried and perhaps didn't work the way it was intended, where we as a state agency could provide examples of programs that work and provide examples of published level reports about cost effectiveness and really create transparency around some of these efforts.
Other thoughts? If we can move then to the next slide, I know I'm used a bit more time. So I wanted to bring this to everyone's, the commissioner's attention, that themes that I thought were missing from the retreat. These would be on the recovery bracket, if you will, as we think about, what the priorities are for the commission moving forward that weren't discussed, but certainly they have been priorities in the past, and I just want to throw them out there as other themes that we can think about. First among those is the diffusion of information technology, adoption of telehealth, among other information technology mechanisms, are increasingly important. The Healthcare Commission has been a strong advocate for adoption of technology as we move into what I would say the next decade in information technology diffusion. What are key roles that the commission can play, I think are going to be important, whether it percolates up to a key theme or not, because there is a lot to do. There are new emerging risks as we become a more information anchored industry, as cybersecurity increases in importance, as the threats from hostile actors increase. Do we have roles to play in terms of educating our industry to supporting the adoption of technology that would insulate these organizations from some of these threats, I think, are questions. And how do we translate this technology to make it equitably accessible to all members in the community, I think, are still questions that have not been answered fully. And we see that in discussions that go on every day with concerns that certain segments of the population, minorities, rural people living in rural areas, are left behind, either because they lack the technical equipment or the technical infrastructure to access these new tools. We also are recognized as playing a key role in in facilitating the adoption of new models. We play a role in the primary care model. Are there other models of care that we can certainly play a role in? Historically, that's been one that we have aspired to, and one in which I think there are opportunities going forward. A third area is seeing ourselves as an agent producing information, but not necessarily seeing ourselves as the end user of that. And that's most obvious in the use of the all-payer claim information, where some of the primary users of that are fellow sister state agencies, and really aligning, making their needs our priorities as we work together in making information available for decision making, I think is a key priority. Currently, as most of you know, we have consulting relationships on our cost and quality information with HSCRC, the Prescription Drug Affordability Board, the Maryland Health Benefit Exchange, the entity that was set up to build out access to insurance in Maryland as a result of the ACA. And then lastly, the Maryland Insurance Administration itself. And we can, I think, elevate those relationships even further, certainly spawning relationships in other agencies within the Department of Health, I think are extremely important, moving beyond Medicaid, which is an important partner as well. And then lastly, I think one role that we don't give ourselves enough credit for is that we are an incubator of other entities. We've spawned the development of the Maryland Patient Safety Center, which itself has had a rebirth over the last several years with the selection of a new executive director, CRISP, and to a somewhat limited degree, the Prescription Drug Affordability Board as well. And it's not as apparent with the Prescription Drug Affordability Board, but our administrative staff have done enormous work standing that up. It's almost like we are a business development entity for that organization over the last 2 years that I want to commend our administrative staff for. Do we really think about that as we spawn other organizations that ultimately can work with us in collaboration to meet some of our broader goals? Our ideas that I thought were worth mentioning here as we think about our priorities moving forward. And there are others that we would certainly welcome, as we're really still at the percolation process in the development of priorities, that we welcome thoughts from commissioners in the next several months. As I said at the retreat, during the legislative session, we kind of are planning on taking a pause, but that doesn't mean that the idea generation necessarily has to stop, however. And do you want to talk a little bit about the next steps if we jump to the next slide?
Sure. Can we have the next slide? There we go. So in our conversations with Ben, we had talked about a pause until the legislative session is over in April. He felt in terms of your workloads, although absolutely for what Ben just said, that doesn't mean the conversations or the idea generation has to stop. It just means we weren't going to make specific demands of your time during that time. Over the summer and fall, we plan to interview representatives of selected outside entities whose perspective we may have not been able to capture hold 2 mini retreats and then continue to polish these themes and priorities and fill in gaps, such as, I think Ben bringing forward those unmentioned themes and trying to make sure we flesh those out and incorporate them, to end with a November retreat, I think, kind of a follow-up to last November's retreat, and then we would deliver a final report. This is all based on our conversations with Ben, really open to any of your suggestions about other background work you'd like us to do, things we can bring to you to help with this process.
Thoughts from commissioners on this timeline? I can call on some people if that would help. Commissioner Dordan, what are your thoughts on this?
Well, probably no surprise, the sooner the better, but I do realize that we can only do so much. But again, I think if we could, a couple win-wins would be great. If we could figure out a couple things that we could do and really concentrate on them. I mean, we can't save the world and do everything at one time here, but and to me that all of us have something to offer, but clearly Ben and his staff will have to lead this whole process. That's just the way the life is and the way it should be with the executive. So I would, say to Ben, where's the biggest bang for the buck, and what could we as an organization do? And set priorities and a time frame, and by this fall, maybe when we have that retreat, have done something. I think it would be great.
What's the interview of representatives for selected outside entities? Why can't that happen in conjunction with the legislative session? I'm not sure I understand.
No, that's actually a great point. There's no reason why we can't get started on that now.
We could prepare for our first mini retreat here of the 2 in perhaps May, which would get us ahead of this and perhaps, be well on our way by November to doing something.
Okay.
Dr. Pollack, which outside entities those representatives are going to be?
We're open to your suggestions. In my conversation with Ben, it would be very time intensive to interview all of you commissioners. Although, you all have your role as commissioners and you also bring really important outside perspectives. But we hope we're capturing that in the mini retreats. If there are entities that we can interview and sort of gain more information, I'm trying to think of a good example. The Hospital Association or AARP, or I don't know that we have some real aging. We can reach out and interview the leadership at CRISP if there are questions about the data goals. So that's something after we write up all of your input today and talk with Ben about that. But we're also open to any of your specific suggestions. And I would say, we can interview, identify some people now, and more may come from the conversations at the retreats. It's certainly something we can do on an ongoing basis.
I would say the county and city health officers. I think we need to understand what challenges they're facing, and how we can better provide resources to them. I want to know, what are the impediments that we can shine a light on or potentially address with regard to population health in various jurisdictions. It seems like that's a resource that we haven't tapped yet.
This has the commission only basically holding 2 mini retreats, and then we have a retreat in October, and that's pretty much our involvement with this process. do we need some sort of a work group or subgroup of the commission that could give feedback throughout more finely or refine ideas or things like that?
You mean like a strategic planning committee of the
Yeah, kind of like that.
commission? I think that's a great idea, Randy.
Yeah, I guess exactly like that, really. I think I could use the right words.
Yeah.
Dr. Pollack, do you want to think about, how you would select that?
I'm already thinking, yeah. Absolutely. Be careful what suggestions you make, Commissioner Sargent.
There's always a danger in suggesting a committee.
Yeah, isn't there? So Ben, maybe you and I could talk about that this week or next week, and maybe reach out to some folks. If there are volunteers, please let Ben know, and we'll get you involved. But I can think of 2 or 3 people who have been, who I think would be exceedingly valuable, but I'm sure many more.
Is it appropriate to have a Medcaid leadership also, somebody from Medcaid involved in this, or you don't suggest?
It's our I think we should interview Medcaid as part of this process, without question. But I'm hesitant to take a group like that and put them on our strategic planning committee, but for fear of leaving somebody out, right? So we'd want nursing representation. We'd want representation from the payers, representation from the big employers. I mean, you could go on forever, but I think that certainly Medcaid is one of those groups that you would absolutely want to be interviewing in this process. Absolutely. As well, physician board and the nursing board.
Okay. Got it.
Yeah, I think, and Dr. Pollack made the point that if we can get the report sooner, I think you made the point that we see the report as aligning with the new administration, but it needn't wait till release. It may not be done, but it may not need to wait until it's who the new governor is before we complete it. That we can uncouple that and work at our own pace. We don't need to have a unveiling, if you will, but we have to recognize that having a document that we can show to the leadership of the state, I think, is valuable to put us in place as having an important role to play over the next 4 years.
I agree. I think it'll be great for us to have a roadmap that the new administration can potentially either buy into or modify or reprioritize. But I think the likelihood that the roadmap that we would put out would be one that would be controversial is unlikely. I think this group is fairly apolitical in terms of the way that it approaches each one of these questions.
Well, we'll take those. We'll look forward to talking with you, Dr. Pollack. Any final last thoughts before we move to the conclusion for today's meeting? I appreciate, first I want to note that Dr. Pollack did, it was his idea to bring those 2 gentlemen forward. It turned out that there was an enormous amount of interest, and I know that a few people had questions that are still we're going to get answers from, but everyone's attention, I think, was really appreciated by MHA, and I think we all found it useful to get their perspective and have a better understanding of areas where we could really complement their work as we continue to work through the pandemic. I would say that we are working towards having a speaker at the February meeting, it is a bit more challenging in the long-term care community because there are actually 3 organizations that represent the industry. So unlike the Hospital Association, 3 people might want to speak, but I don't believe we'll have time in February for 3 representatives. So have to figure out who's most appropriate, or perhaps we might have an owner. Commissioner Emts wasn't here today, but I'll consult with him in terms of if any suggestions he has. But they certainly have played a key role during the last 2 years as well. In terms of the meeting itself in February, we do expect to have at least one of our contested cases come before the commission. We will expect to spend some significant amount of time on legislation. We have the happy series of events, as I think is well known, in that the state has a lot of money. And when that's the case, everyone has their projects that they want to fund. We likely will bring some of those proposals in the health arena forward. There are also going to be efforts to align what's happening with the total cost of care with what private payers would like to do in value-based payment initiatives, a so-called Care First value-based model. I think it will be introduced shortly, and we'll bring that before you for discussion. It's an important effort on the part of all payers, although Care First is taking the leadership role in that. We also expect to see some efforts by CRISP to expand the scope of information collection that they are responsible for. That legislation has not been introduced, but it will be likely a topic that we would discuss in February, if not before the meeting, at the meeting itself. So some fairly sizable proposals are going to be presented to the commission. Stay tuned. We don't exactly have the schedule for those, as they have not been introduced formally. So we'll look forward to seeing you at several of the Thursday morning meetings between now and the February meeting on the 24th.
Great. Thank you, Ben. Any questions for Ben? Hearing none, I'll entertain a motion to adjourn.
So moved.
Second by Dr. Bhandari, moved by Commissioner Sargent. Any opposed? Take care. Thank you.
Thank you.
Thank you, everyone.
Have a nice
Bye.
day.